Good evening, everyone. Here, Dr. Imran Abbas from Dubai. Again, we are live with Professor Laurent Layani. Professor Layani, he is a big name of bariatric surgery, and we will follow our series of mini gastric bypass and one anastomosis gastric bypass. So our interviews will continue with these legends. So what is our target? Our target is to know more about MGB and OAGB, and especially for us, for youngsters, so we can hear these legends, so their experience, they will share our experience. Sir Laurent, highly welcome, and again, thanks for your time. For in I know you are so much busy, but we need to hear more about MGB, OAGB from your side. Welcome, sir. Over to you.
Well, first of all, thank you very much for the honor to invited me, and I will like to congratulate you for your interest and all the effort you put in this academic adventure, I will call. A few weeks ago, or last week, I think, was Dr. Ratlish. Today it's me, and your program is look like a very good program to me. So I'm very honored to help and to give you a little bit of insight and I mean, obviously, to give you a little bit of my experience in a sort of a less formal way, in more informal way, which I think is going to work very well for everyone, not just with me, but with everyone you're going to interview in the next few months. I think people will like this if we can stay some kind of a focus in the questions and not get lost in. So I will be more than happy for you to direct me to your questions to make sure I don't get lost in my sort of madness. Uh, so
Thank you, sir. Sir, first question is your brief introduction. So
I, I,
we
I, I, I'm,
also.
I'm going to give you a very quick, brief introductions. First of all, I'm 58 years old. I start. Basically an old surgeon. I can call almost now. I'm a laparoscopic surgeon because I've learned on my own. Basically, it was nobody to teach me at the time. I start my surgery with gynecology, so it was a little bit easier for me when I start when we start doing laparoscopic cholecystectomy in France long time back as a resident. I was coming from the gynecology training program, so I was always interested in laparoscopic surgery. Nevertheless, I am trained basically an upper GI hepatobiliary surgeon before laparoscopic or bariatric. So I'm HPB surgeon. Did a lot of liver transplantations and pancreatic surgery. Nevertheless, in 1994, I went to Australia from France to do 2 years of postgraduate fellowship, and I stayed 3, and I stayed 4, and I stayed 24 years basically.
Excellent,
So
sir. Sir, your journey of bariatric surgery.
my journey of bariatrics start with my mentor, the Professor George Fielding. I don't know if George is going to listen to this. I think he probably will. I'm going to send him a link. George is now in New York, NYU, practicing as a bariatric surgeon. And in 1998, I did my 4th year of postgraduate fellowship in Brisbane. It was my 4th year, always with the intention to maybe return to France. And then I start this journey with George when it became like madness of laparoscopic banding in the world. And with George, we used to do bands after bands after bands after bands after bands. It was unbelievable. And also, um, George at the time start to have this interest, which was basically because of this kind of a connection with Mount Sinai and Michel Gagne when he was in New York at the time in Mount Sinai, to embark himself on the laparoscopic BPD. So
Yeah.
believe me, this was
Yeah.
it was something out of this world in 1998 when you used to assist George doing a laparoscopic BPD or Marceau DS, and it was not like now. It was something else.
Yeah. Yeah.
It
And
was
sir, in
tough.
my opinion, after 20 years, maybe then we will see another change because this bariatric surgery is still in evaluation process. We cannot ask, so this procedure is perfect. No, still, I think bariatric is still in evaluation.
Well, you can see the evolution. I mean, 98, 99, 2000, 2001, 2002, and all was banned all around the world, except in America, remember, because it was not possible to do banned in the US. This is why George went to the US and I was accompanying him sometimes. But then we start basically seeing some problems, and then we start doing laparoscopic sleeve gastrectomy. So the sleeve gastrectomy coming from Michel Garnier first meeting in New York when he was telling us how difficult was the laparoscopic BPD, how many complications he was having with laparoscopic BPD. BPD modified with a sleeve and the anastomosis, and he basically thought himself to himself, let's do two stages. Let's do sleeve first, and then we will do the biliopancreatic diversion later. And then suddenly they realized then this is how the sleeve starts.
Yeah.
This is how the sleeve basically is born. It's born because they realized then a lot of patients didn't need a second stage.
Yeah.
And suddenly explosion of the
Sleeve.
sleeve
Yeah.
around the world,
Yeah.
particularly also on the surgeons like me and George and others, where we have to offer something to our failed band.
Yeah.
What are we going to do with our failed band?
Yeah.
Nevertheless, this is once again the evolution 2001, 2, 3, 4, 5, 6, 7.
Agree, sir.
And suddenly I have the chance to come to I went to see my parents in I think 2008. I go in Paris every year, and it was the first. It was at the one of the private clinic where Chevalier and Ratlish and a lot of world surgeon, they were doing it was the first uh, consensus on mini gastric bypass. I think it was 2008. I think I don't remember exactly. Nevertheless, the guy was organizing this. It was a friend of mine, and he said, "Oh, we come to the OT. Today is the OT day. We booked 3 OT, and we're going to do 8 cases. Just come and you can scrub if you want. You can just play whatever you want to do. Just come to have a look at this new technique."
Yeah.
And this is how I met basically Ratlish, and I met, to be honest, the first time I met Jean-Marc Chevalier at the time, and other guys which I didn't met because they were downstairs and me, I was upstairs in the OT. I was some kind of it was a coincidence to be part of this new mini gastric bypass consensus, because I was not planning to do this, and I was not planning to do any kind of surgery. I was going to see my parents and just having good time. But nevertheless, this was a very interesting day. And from that, I returned to Australia in my practice. And I was always a little bit controversial in a way when we start the band and when we start doing something else and when we start doing the sleeve. It was always going. And then I start to introduce the laparoscopic mini gastric bypass. Now it was basically completely, it was not really accepted. It was, why do you do this kind of surgery? Plus, I start laparoscopic mini gastric bypass basically for revision. I didn't start for primary. My idea was what I'm going to do with my failed sleeve, and now it was what I'm going to do with my failed band and my failed sleeve, because I have two kind of group of patients: the failed band, which I, at the time, was converted to the sleeve, which I think it's a wrong thing to do, but we can come to this a little bit later. And I was also facing some new problem, which was a lot of bands, and some bands after 3 or 4 years coming back with weight regain or reflux or issues, what I'm going to do with it. So my first thought was, okay, this mini gastric bypass seems quite interesting. It's more a malabsorptive operation. My experience with George and the laparoscopic BPD, except of the fun I have with him doing surgery, was certainly not a great experience patients-wise. The complications and the vitamin deficiency and malnutrition of this operation is tremendous. And actually, I never really like it at all. In fact, in my practice, when I start, I done one and I stop. I don't like this, but it's another story. So the complication was too high. And so you can see sometimes, I don't know for you, but many times in life, you have this kind of opportunity. You see something, you listen something, you go to a meeting, you met a surgeon, and you come back to your practice and say, well, I think this mini gastric bypass sounds interesting. Like you did, for example, when you introduced this to your friend in Pakistan, and now you can see the Pakistani society are getting onto it, and suddenly it's become like a snowball, and there's a lot of interest, and you can see it's obvious. And when I introduced this mini gastric bypass in Australia, nobody was doing it. It was criticized, but my fellow was supportive of me. Some of my friends, they were supportive of me. They start doing it. They like it. And suddenly now, a lot of people doing it. I mean,
Sir, I have a question. So during this period, so now I know you are one of the busy bariatric surgeon in UAE, and long time you are here, and your main practice is also mini gastric bypass or one anastomosis gastric bypass. My question: during this time when you have started this MGB, have you changed your technique of MGB for better results? Like length of pouch, size of gastrojejunostomy, or have you changed your technique?
look, doctor, I mean, you know, and I know that if you don't change your technique, then it's something wrong with you.
Yeah.
We all get slowly better. We all realize that what we did, it's not what we do. And interestingly enough, when I look at my video of MGB, because we talk about MGB tonight, from 2008 or even before, or 2000, I don't remember when I did the first one back in Australia, and I look at how I do it now. Sometimes I look at the video and I think, is it me?
Yeah.
Is it really me?
This is
You,
reality. Same
you,
with me, sir. Same with
you,
me. Because
you,
really, I agree with you.
you think, no, this is not me.
Yeah.
How can I do this? You realize then, my God, what I'm doing. Anyway, my point is, it is true that we all make some changes.
Yeah.
We all adapt our technique. I am not really so fussy when I do a lot of teaching. I'm left-handed. I teach the right-handed. I know Ratlesh has his technique, and you do your technique. I watch your video on YouTube. I watch almost everybody like you. At the end of the day, what do you I can say about mini gastric bypass? First of all, I realize then, after about, I would say, 500 patients, when you operate 500 band, 500 sleeve, 500 gallbladder, 500 of this. It's a big number. 500 is not a small number. It's not massive. But when you have reached this kind of number, I feel then you become like you have this kind of routine on your technique. So you have tendency to change along these numbers
Yeah.
slowly, but one stage, at one stage, when you arrive to this kind of number, you hardly change again. You sometimes pick one little thing here and here, but you hardly change again. I still do the same lap band, still the same band than I used to do in 98, perhaps 99 with George Fielding. I mean, I do maybe 3 or 4 bands per month only, or even 2 now. But I have not changed too much of my technique. Now you can say to me, is you remove one trocar to do one. I don't believe on this. I feel I do the way I like to do it and the way I like to teach it. But the answer is yes. So if you ask me some specific, do we do I have basically I feel then I have make I with time I have reached the maximum length of the gastric tube. I
Excellent.
think
Yeah.
when I start, because it was not too much really many people to teach you anything, I was probably doing a pouch little bit shorter than what I do now, because now I really do as long as I can. I mean, because it's a limit of how long you can be, but you do as long as you can. The rest I have also learned of the perhaps I have always been very aggressive, and I always, because of maybe of my upper GI training program, I always try to repair any defect around the hiatus. So when I listen Dr. Ratlish, which I respect, which I think he doesn't
So,
need
sir,
to
we
repair.
will go. We will go ahead. So, regarding,
Tell
so
me,
I
tell
will
me.
ask this question. So, one question regarding contraindication. So, if you see, you are going to select your patient, which is contraindication of MGB.
Well, if you want to start with contraindication,
Like,
the
if sir has explained. So,
sure,
yes,
sure,
we
sure.
all know cirrhosis or
No,
some
no, no. Sure, sure,
leopard.
sure,
Yeah, yeah.
sure, 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 sure. Uh, First of all, you have the what's I call the um, the contraindications you know beforehand.
Yeah.
What I mean is, if you have a patient, then you know this patient he has cirrhosis. You know this patient has portal hypertension because he's coming from a liver clinic. He's coming from whatever gastroenterologist is perhaps on a liver transplant program, and they want him to lose weight before liver transplantation. You have a patient, this is one group. Then you have the group of patients coming from the gastroenterologist uh, with Crohn's disease or query, what you call inflammatory bowel disease, which is patients is on medications, is clearly diagnosed properly, and this patient requests some weight loss surgery. I, I believe this is the two main biggest contraindication, with perhaps the third one, which is very rare, as you know. Everybody's talking about this, is this patient with Barrett's esophagus. How often do you see Barrett's esophagus per year when you look at all the patients you treat? It is very, very rare. Nevertheless, if you have a patient with severe liver disease, with portal hypertension, if you have a patient with uh, chronic inflammatory bowel disease, if you have a patient which requests some drug medication which is going to be perhaps absorbed by the small bowel, and these patients will request medication for disease like you sometimes have no idea. Disease coming from the rheumatologist, disease coming from perhaps even an oncologist, disease coming from a neurologist, and you know that this medication need to be absorbed. And you have the patients with clearly diagnosed Barrett's esophagus with biopsy. This one don't do an MGB. Basically.
Excellent, sir. Really appreciate. So now we will go for so one of the main concern of MGB is reflux and GERD. So this is the overall concern. So have you this concern? Now after 12 years, at least you are doing MGB. So you think this is a concern after MGB?
Well, maybe I'm going to make people jumping from the chair, but I am more concerned about reflux in patients with coming for sleeve than I have patients concerned with patient with symptomatic reflux coming for or going for mini gastric bypass. So if we make it clear what I have changed in relation to get something very didactic and simple. Before the time I was doing mini gastric bypass, I was doing very few. I never really liked the Roux gastric bypass, but nevertheless, I was doing some, and mainly doing bands and sleeve. It was not as an issue in the world before until the last few years. For the surgeons to get any kind of issue with reflux, patients with symptomatic reflux, and offering the patient a sleeve. So basically, we used to do patients with symptomatic reflux. I used to sleeve patients with hiatal hernia, gigantic hiatal hernia, intrathoracic stomach. I sleeve everyone and anyone. It was sleeve after sleeve. It's like with the band after band after band, whatever band with this problem and this problem. Now, right now, I think if a patient comes to see you, or a patient comes to see me, particularly here in UAE, as you know, most patients request and like to have a sleeve. I mean, it's just a fact. Yeah. It's because my cousin had a sleeve. Doctor in Iranian hospital is doing a sleeve. I want a sleeve, and you want a sleeve, and you try to say, no, you better to have a bypass, and it's a big headache, and they don't want a bypass. Why you want a bypass? My cousin had a bypass in somewhere in Abu Dhabi, and they stay in hospital for 4 weeks and have. And you just go crazy. You say me, which bypass did you have? Nevertheless, let's go straight. I believe when a patient has symptomatic some symptoms of reflux, which is very common in the obesity population. Yeah, very common. It's part of the disease. If you see most of obese patients, if you speak with them, they have some kind of reflux issue. So if you basically say that you're not going to do any sleeve on any patient with mild symptom reflux, basically you're not going to sleeve anyone. And if you say that I'm not going to do a mini gastric bypass on patient with some symptomatic reflux, then you're going to do 0 mini gastric bypass. And then you're going to say, well, everybody has some kind of symptoms of reflux, and I'm going to do a Roux gastric bypass on everyone. This is what some people do, but it's not what I do. What I think is, and this is I've learned with time, I believe that patients with symptomatic reflux issues, with taking some proton pump inhibitor, patient with diagnosed or history of hiatal hernia, which is confirmed by endoscopy. If you can convince this patient to not go for a sleeve, it's very good. I think this group of patients is one group where I strongly believe they do very, very much better with one anastomosis gastric bypass. And you know, then first, the weight loss is going to be excellent. And on top of this,
Yeah.
the reflux is going to go. The reflux will disappear.
Yeah.
The story of,
Yeah.
and I'm going to come to another story a little bit later when we're going to talk about the revision sleeve to MGB for reflux. But I'm going to come to this.
Sir,
So this is one important group of patients. Now, it is true to say, Professor, then some patients, they don't want. Basically, after whatever you're going to say, they're going to say, I don't want the bypass. So you're going to say to me, are you going to do a sleeve for them? The answer is yes. I will sleeve the patient and I will explain to the patient. Then I explain to them. Then they have a risk of have some worseness of the reflux symptoms, and I have explained this to you, and you don't want this. The weight loss is going to be all right, but if you come back to me and you complain to me, then your reflux is worse than before. At least I told you, and you sign.
Yeah.
Okay.
Yeah.
Full stop. But and I know there's some patients that still going to go for a sleeve, and it's fine.
Yeah.
I have some patients, they come to see me and they have a large hiatal hernia. They still want a sleeve, and it's okay. I will repair the diaphragm. Sometimes I will even repair the diaphragm and mesh the diaphragm with a bioabsorbable mesh because the diaphragm is too wide, and I will sleeve the patient because this is what they want. In theory, these are better to not have a sleeve, but it's okay. Why it's okay? Because you know and I know. Then if for any reason they fail with they will rarely fail with the weight loss at the first 2 or 3 years. But nevertheless, if anything happens, we can always change this patient to another operation very easily.
Yeah.
So we didn't cut our leg. We are not in a too difficult situation where you have one operation and then you need to just try to convert to something else. Is why I believe Roux-en-Y gastric bypass has a very, very short future. I believe strongly, and you're going to see then less and less and less people are doing it, because when to deal with these patients when they regain weight and when they have some reflux or when they have any other problem, it is difficult to know what to do.
The small pouch and also dissection at that area.
It's not
Yeah.
And then you want to do a
Agree.
distalization. You want to do a band around the pouch and this and that, and it is not easy.
Yeah, it is. Yeah, you have less options. Sir, another question regarding MGB. So, if you are going to do MGB or OAGB for a patient with hiatal hernia, so what you will do? So, are you prefer to repair this hiatal hernia, and which size you want to, if you are going to repair? So, have you any criteria to repair this hiatal hernia? One question, and next question, same with hiatal hernia. Have you any experience? You did MGB with a patient with large size of hiatal hernia without repairing hiatal hernia, and situation worse after surgery.
Now listen, my dear. I first of all, to answer your questions, I repair every time I see a weakness, an indentation, a hole, a small hole, a big hole in a diaphragm. When I do a sleeve and or an MGB, tonight we're talking about an MGB, I repair every single one all the time. I believe very strongly, then if you don't put a good liver retraction, if you don't have a good exposure of the upper diaphragm, if you don't retract the left lobe of the liver properly, most of the time you're going to miss a lot of small diaphragmatic defects. You're not going to even look for it. I see my friends doing this, And they don't care. They say, I retract with the gun, I retract with this, I do this, I do this, I do this and this, I do my pouch. They don't look for it. So if you don't look for it, except if it's a hole that big that you cannot not see is in front of you, you're not going to repair most of them. So more you look, more you repair. So is why I respect the attitude of who is not doing it. For example, Ratlish and some of his colleagues and team, they're going to say, okay, it's no need. The diaphragm, you don't need to play with the diaphragmatic defect. You do your pouch, you do your gastrojejunectomy, and it's going to pull the complex. The gastrojejunectomy will pull the complex down, and is not going to be necessary to fix the diaphragmatic weakness or defect, which is not true, because I have seen so many times migration of sleeve in the chest, migrations of mini gastric bypass in the chest, migrations of rural gastric bypass in the chest, and most of the time, believe me, my friend, from other guys coming from all around. These patients, sometimes they're not symptomatic, but sometimes they are. They have the gastrojejunectomy or the upper stomach in the chest. I think, listen, even if you repair very well any diaphragmatic hernia, you know and I know, then this can happen anyway. Even the best surgeon in the world can have migrations of the sleeve or migrations of the mini. But I believe then if you know how to do it and you are quick to do it, I do it all the time. I train my guys to do it.
Excellent. Sir, another question that already we have discussed about this GERD before surgery. So this is maybe symptomatic, also documented. Yes, we see in endoscopy, we see, and also you have mentioned already in Barrett cases, you never prefer MGB. So because this was also my question, so in such a situation, if patient is this is my question because already you have answered. Barrett, you never prefer OAGB. Okay, but patient symptomatic patient and also documented reflux. This is the question. Documented, yes. Your endoscopist, your gastroenterologist confirmed there is a reflux, and you did surgery OAGB. So, have you faced this situation become worse after MGB? This symptomatic documented reflux. Have you faced?
Listen, I'm going to tell you the truth, and the answer is clearly no.
Yeah, yeah, agree.
I cannot tell you more. The answer is no.
Yeah.
In fact, I have seen most of the patients have the reflux improve.
Sir,
And
this is same my experience.
I
Yeah,
swear on God, it is the truth. I'm not, I mean, if it's, I'm not a sort of guy which I lie or I hide. I have operated a lot of patients. I have every complications on the planet you can discuss with me,
yeah,
because the more you operate, more problems you can
yeah. See,
see.
yeah, sure.
But this situation, no. Saying this, I have seen in the past when I was not so interested, or because he was less interested around the world about this reflux prior to a sleeve, I have seen a good number of patients, not a huge number, but a good number of patients, which after sleeve and symptomatic reflux, their reflux become much, much worse. And this is a truth. This is a true story. So when you see this, you feel, then it is not is what I'm coming back to what I told you before. You feel that this is not the good operation for this group of patients, because you know that it is possible, it is not always, but it's possible and more likely than this symptomatic reflux patient before the sleeve will have some risk to have more reflux after this.
After the sleep.
But after the MGB, my dear, no.
Yes. Sir,
Not
now,
yet. No, when I say no, not yet.
yeah. Sir, now we will go for some technical questions because that are also important because we are also following MGB, that is the original technique, as well as we are following Carbaho OAGB, one anastomosis, gastric bypass, and also sometime I ask because personally I take some points from Carbaho follow as well as follower of Rutledge. Now this is single anastomosis gastric. I don't know what we are doing. So now my question regarding for your technique that you are doing MGBR, OAGBR, single anastomosis, gastric bypass. So my question regarding landmark of your gastric pouch. So your first stapler is from epigastric or no, from right upper quadrant, and your position is French or you are at the right side of the patient.
Okay, so first of all, we are, in fact, when you talk with most of the, and you will see in the next few months, we all have a mixture between MGB, OHGB, my friend from Spain, my friend from this and this and that. Everybody has a little bit of a mixture,
Variation, yeah.
variation. I do not and never use an epigastric port to staple to apply my first shot. Why? I don't know. I feel it's not very convenient for me. My liver retractor is there. I don't, and if I use this 12 millimeter trocar uh, uh, at 12 o'clock kind, I feel that this trocar after one shot is useless. It will not serve for anything else except the purpose of one shot, because you cannot play with this trocar doing anything else anymore. But this is my point. And I feel that I don't need this. But he has a point. He has a point because it is anatomically very correct.
Yeah.
Right. I know you are a very you like the technique, and me too. But it is true. It is very correct because he's coming down north to south, and he's going to be, without pulling, without playing too much, he's going to staple as low as possible, not too low to not obstruct completely the gastric remnant, because I have seen guys doing this, but nevertheless. But you can achieve almost as good as, with perhaps a little bit of change. But I'm not going to argue too much about this. Now, I am a left-handed, so I stay on the left side of the patient.
Interesting.
And I am French, but since 1998, in 94, I went to Australia and I was still doing French position 94, 95, 96. In 98, when I went to Brisbane, George was operating flat. Les Nathanson was operating flat. And they really give me, these are two very, very important people. Les Nathanson is the guy who had designed the liver retractor, by the way. Wonderful man, wonderful surgeon. And they both were operating on the side. So I start operating on the side as a left-handed, so a little bit changing. So my MGB, I do all the operation from the left, except when it's time to do the anastomosis, I shift to the right because it's obviously more convenient. And it's okay. And it's okay if you can do from the left, you can do from the right. I help my right-hand surgeon to do everything from the right. I suppose you probably stay on the right, or you stay between the legs if you're doing the French technique, and it's fine also.
Yeah.
So, as long as you are comfortable,
sure, sir.
Everything is fine. I use 212, 25 plus the epigastric incision for the liver retractor. You're going to say to me, Laurent, why do you need 2.5 and 2.12? It's because I do.
Yeah.
I like it. I like to have my retractions. I like to have my assistant doing this. I feel it's my little diagram. I use actually, sorry, I use 1.5 and 3.12 for the MGB, same than the sleeve.
Yeah.
For the revision sleeve to MGB, I use 2.12 and 2.5. But nevertheless,
Sir, excellent. So regarding, so we have lot of questions from our viewers. Now I can see at the end. I will try my best to select some
tell
of
me,
them.
tell me.
But sir, we have another question regarding BP limb. That is also the most important question. So how you select this BP limb for?
No,
Yeah, yeah,
so I think this BPLIM, and I hope my following colleagues will agree with me. This BPLIM, I think, is probably the most important change I have made in this entire journey with MGB. Why? It's because it's basically what we have. We start without knowing anything. We start seeing things. We start seeing complications which we didn't actually anticipate it, or we try to ignore. Say, no, no, it's never happened to me. No, 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 no. It's happened to him and not to me. Well, and it's very, it's a very simple thing to change, because if Mohit said to me, Laurent, I used to do a 2 meter, now I do a 180 and I see much less complication. Well, for you and me, it's a piece of cake to change 180 to 200. You just have to stop counting. If you, so, and this is basically experience with long-term data, because it's not happening at the time. It is the long-term experience where we have seen some changes. So I have to say, I have not changed that much myself. I more or less doing a 2 meter bypass as a primary surgery. Where I have changed a little bit is because we now have more patients coming for metabolic surgery, which are BMI 30, 32 with diabetes. I think these patients, you can easily go much lower than 2 meter.
yeah.
These patients, you just have to basically bypass the duodenum. At 1.5, you take no risk.
Sure.
At 1.5, you think, I'm bypassing the duodenum. I'm excluding the food from the duodenum. I win the battle with the diabetes.
Yeah.
At 1.5, no way I'm going to have a malnutrition on this patient.
Sure.
And their body mass index sometimes 28, 29. This one, I agree. You have to be intelligent and simple. We're not very smart as a surgeon. We just have to be simple and clear. When I speak with my friend in England, and they all agree, they are going down from 180, 160, even 150. They are thinking now, why not? For even BMI 40 plus. Where I was interested to hear yesterday was a webinar with India, and it was always the same kind of discussions of revisions, but you cannot give too much information. Where I believe you need to have a certain opinion is when you do a revision sleeve to MGB, because I am strongly believe that revision patients, they don't do as well as a primary patient. And I believe then you need to extend the bypass when you do a revision patient. Even if you do band to MGB or sleeve to MGB, you make it longer. Now, it is become more and more in my practice, perhaps because I have been more interested to listen my friend from Spain, Dr. Carbajo, which I think is a wonderful guy, with the guy from Mexico. because
Thank you.
obviously they are counting.
Yeah.
Okay, they're
Yeah.
doing for
And
everybody.
yeah. And
They are counting the small bowel. I respect this. They count and they do 60, 40, 60, 40. It's like a religion. When you do this, they have very little problem with very, very good results. For me, counting the small bowel, and I'm sure for you, it's not a big deal. It will take me maybe
5 minutes.
okay,
Yeah.
5 minutes, okay,
Yeah.
or 6 minutes, okay. How often I'm going to perforate the small bowel? Probably never, or maybe one every whatever if my assistant's doing this or if I had. So really, it's let's forget about these discussions of time and dangerosity, because if you know, we need to come to some kind of, this is why the Americans, they want to know this. They, if we want to sell the operation to the US, we need to have a very good idea of what we're going to tell them. We're going to say we're going to do this pouch, how long is the pouch, and how long is the bypass, and if we can have 60, 40 and count, I think they probably will one day
Accept.
accept
Yeah.
this
Yeah.
operation.
Sir, regarding this question, already you have answered.
So,
So
let me finish it 2 seconds because I didn't want to lose my memo. So when I do revision, I have two things. Revision, I think, need to have a longer bypass as a principle. Whatever you normally do, make it longer. I feel that if you pass 2.5 meter of bypass, erratically, I feel in the bottom of my heart that it's time to start counting the rest of the small bowel. Because you know, you don't want to have a problem and find one patient you do 2.5 or 3 meter and suddenly this patient's got 2 meter left below. So if you want to start of a, I finish on this. Do you need to systematically count the small bowel? The answer all around the world is at the moment, no. You know that. Most of the guys are the Spanish guy, they will say yes. Most of the people, they say no, no need. If you wish to extend longer because it's revision, because the patient need to lose more weight, because it's a revision after revision is complicated, is it this moment time to count? The answer, if you pass 2 points, the answer is yes, do. Spend some time. If I was more in an academic center, perhaps like a Mohit with the number is doing it and he's doing this. No, you know, it's actually, it's interesting because nobody is doing any kind of study of the length of small bowel and studying on percentage. You have one group is doing it systematically, and the other group is not doing it. Basically, is nothing in the middle.
yeah, sir, as I understand, in redo surgery, so you prefer to count total small bowel, and also this common channel is more important for you in redo surgery, and at least 300 plus you preserve or save this common channel, as I understand.
No, the 300 no, the common channel is nothing to do with this. It's something, if I do count, I go straight to I follow the rules of Carbajo because he has studied it, he has published it. And when I count, I go 60-40.
No, 60 will be BP in redo, or 60 will be common. This is my question.
No, 60 is, 40 is common.
40 is, okay. Thank you, sir. So our
No,
next
because
question.
no, remember the Spanish group, they are, you have to be clear. The Spanish group for primary or revision or whatever, they
If
counting and they are doing the biliopancreatic limb 60%, common channel 40%. This is what they do.
no, no, sir. Just for my confirmation and for my viewers, in initial surgery, primary surgery, so they count completely, and 40 will be in initial in primary, 40 will be BP limb, 60 will be common channel. But in redo surgery, 60 will be BP, 40% will be common channel. This is
This
your
is what
point.
they do.
in redo surgery?
This is what, no, this is not what I do. No.
In redo surgery, if you measure like the bowel length is 10 meter, just my
Yeah.
question, 10 meter you measure in redo, a patient, just a patient, after weight regain, after sleeve gastrectomy, now you are going to do one anastomosis gastric bypass
I
for the
will do
patient.
5-5. I will do 5-5.
Right, excellent. Okay, sir.
I
So,
will not. I will go between. I will not take too much. No. I'm telling you the truth.
yeah, yeah,
I'm telling you the truth. If I
agree,
count, if I do a sleeve to MGB and I count the small bowel and is it 10 meter, I will do 5-5.
agree. Sir, next question regarding this is also technique for techniques gastrojejunostomy, the size of this, and also because now side to side, posterior to stapler line. So, what is your preference?
See, once again.
Another question.
No. It's a good question. I believe. I tell you what I do. What I do is I use a 60. I use a 60 millimeter cartridges. I use a blue cartridges for the gastrojejunostomy, and I use my gastrojejunostomy. I do my gastrojejunostomy most of the time anterior,
Anterior.
and I do anterior gastrojejunostomy, making sure I do not staple the gastric tube. So basically, I make sure then the stapling of my tube, it's not included in my gastrojejunostomy. You understand what I mean? What I mean is you have your gastric tube, you staple your tube. If you do anterior, then you are not including you're not putting the staple line, which is on the left side, into the gastrojejunostomy to avoid ischemia. So your gastrojejunostomy is sitting on a free, fatless stomach, because then posteriorly, and I respect posteriorly, when you do a posterior gastrojejunostomy with the same idea of not including the staple line in your gastrojejunostomy, which is the same concept, but posteriorly, you have a lot more fat. And this fat is not just fat, it's quite vascular. So you need to unfat this posterior fat sitting to the back of your tube to do your gastrojejunostomy posteriorly. When you speak with Dr. Ratlish about this, and when you speak about gastrojejunostomy anterior, for some reason, he's going to tell you, they're going to tell you, then a gastrojejunostomy performed anteriorly has tendency to flip. Basically, has tendency to not stay completely straight, because he has tendency to turn a little bit, which is true, which is a little bit true. This is why, and obviously when the Carbajo group, they are doing gastrojej anterior all the time, but what they do and what we don't do, because I know what you do, is they are stitching the the small bowel all the way along the gastric tube to that distance. So after this, the tube and the small bowel are sitting next to each other, and then they do the gastrojejunostomy. So it's not possible when you do this, when you stitch this together, it's not going to do this, because it's already together, and is not going to do this. The risk of the gastrojejunostomy anterior is to have the alimentary limb kinking a little bit, the alimentary lumen, and create a difficulty of swallowing, and create increasing of bile in a gastric tube. This is why most of the time when people talk about bile reflux in a well-established long tube is often an anatomical problem of the alimentary limb, because the alimentary limb is not straight, is not open properly, is doing like a kink, and it stops the bile to going down properly. Unfortunately, endoscopically, you never see it, because you put your scope and it goes smooth. And you think, oh my God, it's all perfect. It all look perfect, but it's not. So this is what I do. And to finish the technique, I believe it is a good practice to fix the alimentary limb to the remanent stomach, which is the remanent stomach close to the antrum or whatever is there. Sometimes it's high, sometimes it's low, sometimes the tube is too low, and then you go low, sometimes it's high, but you know, for two reasons. First is basically keep the alimentary limb straight, means is no risk of torsion, and it's also keeping the alimentary limb, keeping the space below close, means is less risk of what sometimes they are describing as an internal hernia. I have some of my fellows is this actually the full small bowel complex going posterior to the anastomosis, because this space is open, this space is free. So if you can close this space, is good. And following Carbajo, I put a couple of stitches on the biliary limb with the stomach to small bowel.
Excellent. Sir, another question regarding just a case. So this case is the case of sleeve gastrectomy, and due to GERD after sleeve, you are going to, you prefer Roux-en-Y or MGB in such a case?
No, okay, so this is, once again, this is, it was recently a very interesting not Zoom meeting anymore, very interesting webinar on this particular story. I do believe then when the patient, first of all, when you look at the percentage of patients which need to be reoperated after a sleeve for whatever reason, the number one reason is weight regain. I'm sure you agree with me.
Yeah.
The number one reason is weight regain after 3 to 4 years, roughly. The number two reason is inadequate weight loss. Basically, this is sooner than the weight regain, because this patient, they come back to see you after a year or after a year and a half, they were 160, and they come back and say, you know, doctor, I'm still 130, I'm still 120. So it's basically the second indication is unhappiness of the weight loss, of what the patient expected, expectations of the patient is basically the second reason. When you look in your practice or you talk with most of people, how often you need to convert a sleeve to a bypass. Don't talk about which bypass yet. Because of severe reflux symptoms after a sleeve, it's very rare, in fact. It's not common. It's not common. Now, you see sometimes a common situation is a weight regain with some reflux symptoms. For some reason, it's often together. This patient, they come to you for weight regain, some reflux symptoms. Is there a relation with it? Or inadequate weight loss and some kind of weight of reflux. The main reason the patient has reflux after de novo or worsening reflux after sleeve. One is because you have already explained to this particular patient, you have reflux, I don't want to do a sleeve, you want me to do a sleeve, I told you to not go for a sleeve, you come back to see me, now your reflux is worse, I told you, blah, 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 let's change to a bypass. Or patients with no reflux symptoms at all before the sleeve, suddenly after a few years, they start to develop de novo reflux symptoms. But you know, and I know this is why I'm coming to, I'm still with you with type of bypass. Is because what is the reason of this reflux? Is because the sleeve is a reflexogenic operation. The sleeve has everything. When you academically, physiologically study the sleeve, has everything to get patients reflux. Is high pressure. He has a smaller tube. Um, Even if the gastric antrum is resected, sometimes the patient has a wrong sleeve. Anatomically, the sleeve sometimes is not done properly. Patient has a big pouch above it. So my point is, this is why I believe then even if and this is what was a very interesting discussion. Most if you say to me, Laurent, when a patient comes to see you, he has a sleeve, he has some reflux symptoms. You do an endoscopy, there's no evidence of Barrett's. They have a mild esophagitis, perhaps, or none, or mild gastritis. Sometimes, in fact, the sleeve look perfect. Sometimes the sleeve look very good. You think, my God, this patient is regaining weight, but the sleeve look good. You operate the patient, the sleeve look good. Sometimes the sleeve doesn't look good. Sometimes the sleeve is very dilated. The pouch is very dilated. But I do believe that this patient will benefit greatly to have a bypass. And which bypass I offer? One anastomosis gastric bypass.
Excellent. Excellent.
Now, one thing you need to ask me is do I resleeve the pouch or not, and when? And the answer is very simple. You resleeve if you need to resleeve the pouch. It is in front of you. If the pouch is good looking, small, don't. If the pouch is big, I resleeve. On average, to be honest with you, I will say 50-50. 50% of the time, no need, because you don't want to resleeve too small. You increase the risk of leak, you increase.
Yeah.
So if you resleeve big or you don't.
Yeah.
Don't put the gun and shoot nothing and there's no stomach to remove.
Yeah.
You understand what I mean?
That's
You
right.
put the gun and there's nothing there, nothing on
Sure.
the other side.
Sure.
No.
Sir, excellent. And sir, our last not least question regarding your post-op diet protocol in MGB patients.
My post-diet protocol for bariatric patient, regardless of which operation I have done, and I have operated since 1998 from the band to the sleeve, is very much the same. 2 weeks liquid diet, 2 weeks of diet. What I believe is the mini gastric bypass patient, as rightly Ratlesh has always mentioned, it is the truth, the Mediterranean diet, which is increasing the salad, increasing the meat. The amazing thing is, if you compare MGB and sleeve, is the MGB patient can eat better. I mean, it is no doubt about this.
Yeah.
I operate patients from the same family, sisters, mothers, husband. One had a sleeve, one had a bypass. One sister had a bypass, one sister had a sleeve. And they all tell you the same thing. Why? Why I cannot eat? Why she can eat?
Yeah.
Why I cannot do this? Why she can do it? It is because the quality of life of patient in terms of eating, it's much better with mini gastric.
That's better. Sure. Sure.
It is no discussion.
Yeah, yeah, agree, sir. Absolutely agree with you. I have lot of questions. Unfortunately, maybe some of those the question they already have received answer. So, Dr. Fareed, thank you for your questions, and Dr. Abdul Kareem also thanks a lot for your attention and question. Sir, a special question from Dr. Arash Sabrawal. His question regarding vegetarian patients. What is your diet protocol? So, because the main issue is protein deficiency and also malnutrition after any type of hypoabsorptive or malabsorptive surgery. So, in such a patients with patients who are vegetarian, have you special protocol for these cases?
Well, first of all, I just would like to say thank you to Arush. Arush was one of my students in Australia and in India. You know, I live in India and practice with him. So Arush is a good friend of mine, and I have a chance to live in India for a year plus, in fact. So I know what is veg and non-veg more than anybody else, really, in terms of non-Indian patient, non-Indian surgeon. We do offer, and most of my friends from India, they do offer mini gastric bypass to vegetarian patients, but you need to make sure that they do have enough protein in the diet. I suppose the diet of the vegetarian patients are in terms of protein are more in tofu, and they are more in specific vegetable, and it is an issue. To be honest, I tell you something. Perhaps it was an issue. It was an issue in our mind, in my mind, in Arush's mind, in most of my friends from India. A lot of guys, you know, and they're going to talk for a long time, particularly when we start doing this. I'm talking about 2010. I remember I was going in 2010, 2011, 2012. I went Delhi and all the different cities and north and south, which is fair. But I strongly believe that now, if you talk with a very committed Indian surgeons doing mini gastric bypass, now emphasize on the obviously on the follow-up, on the diet, on increasing the amount of protein. To finish this question is MGB a contraindication for vegetarian patient? The answer is no.
Excellent. Really excellent, and it was very, very informative. Your just your I think message for someone who are new and who are going to start MGB or OAGB
Sure.
for such a youngster, sir. Your message.
Well, I would like to, my message is very much the same than I always have all my life. When you start something new, please ask for somebody to help you. Ask for the guy to help you, to mentor you. If he can come to you, you come to him. You come to him, and you do and help each other. This is the best way, and you have experienced this with your colleagues in Pakistan. This is the best way to have the best results, to see people getting better, to not getting stressed with some terrible horrific complication. uh, Mini gastric bypass is not a mini operation.
Yeah,
Sleeve is not a mini operation, you know, and I know.
yeah,
And nothing is mini, nothing is small. Everything is has a learning curve. And when I used to work in a public hospital here in the Ministry of Health, I organized a lot of mini gastric bypass mini fellowship, and it was very successful. The guys were returning from, going to Pakistan, back to Oman, back to Kuwait, back to Egypt, back to whatever country, and they seeing you doing this, and you try to ask them to scrub, and you do a little bit of this, you do a little bit of this. Obviously, it is not always possible for you or for me to go, or to my friend, to go to the other country guys all the time, particularly now in this pandemic. How many times? The second time I canceled my trip to with you in Pakistan, and I wish I will, because this is part of life. It's just nothing we can do about this. And so, and also for the young guys to understand, can they stitch? Can they handle the tissue properly? They need to not be ashamed to ask questions, to learn, to look on the YouTube, to talk with some guys like you, like me, like all the future speakers which are going to come to your channel. And this is the best way. I think it is important for the young one to start also.
Yeah.
We all have started.
Yeah.
So, but start with, be careful. Don't pick the wrong patient. Don't pick the big BMI 60 male with a huge belly when you know it's going to be so much fat in the belly. You're not going to even see the organ. Just try something easy. A little woman with a BMI 38, 40. You know. Anyway, thank you.
Thank you, sir. Really, it was a great session, very informative, and really appreciable for your time. Personally, really, I have learned lot of things, and also thanks our viewers. So now I can see at this time about 600 plus viewers are here with us, and this is a great achievement. And also this video, so they will see, and also they will watch this video, and also again, if you have any question, viewers, if you have any questions, yes, you can ask. And we at the end of this MGB series, we have a sum up session, and also at that time your question will be very helpful. And next week we will have Professor Lee from Taiwan. He is another legend. So due to the timing of Taiwan, because we will be live at 7 p.m. Next week, 7 p.m. Dubai time, because due to Professor Lee at that time in Taiwan will be 11 p.m. So we adjust our time, and see you inshallah next week, same day, Tuesday at 7 p.m. with another legend, Professor Lee. Have a nice time, and if you have any question, welcome. Bye. Thank
And
you, sir.
I love your enthusiasm. I thank you and good luck.
Thank you, sir. Thank you for your support and really appreciable. Thank you, sir.
Bye
Good
bye.
night, sir. Bye. Thank you, sir.